بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. Hypertensive disorders is one of the most important medical disorders during pregnancy. During pregnancy, a blood pressure of 40/90 or more is abnormal. A rise of 30 mm mercury or more in systolic blood pressure or 15 mm mercury or more in the diastolic blood pressure is considered a risk factor. Hypertension disorder in pregnancy, according to the classification of the American College of Obstetricians and Gynecologists, include gestational hypertension, transient hypertension of pregnancy, preeclampsia syndrome, chronic hypertension preceding pregnancy, chronic hypertension with superimposed pregnancy-induced hypertension, superimposed preeclampsia, superimposed eclampsia. This slide demonstrates the definitions of the different types of hypertensive disorders during pregnancy. Gestational hypertension is diagnosed after mid-pregnancy without proteinuria. Blood pressure returns to normal before 12 weeks postpartum. Chronic hypertension with pregnancy is hypertension antedating pregnancy or detected before 20 weeks or lasting more than 12 weeks postpartum. Preeclampsia is the development of proteinuric hypertension during the second half of pregnancy. It may occur earlier in vesical mole or twins. Eclampsia in Greek means flashes of life. It is the occurrence of tonic-clonic convulsions in a woman with preeclampsia. Transient hypertension during pregnancy is hypertension after mid-pregnancy or during the first day postpartum without other signs of preeclampsia or pre-existing hypertension. This condition is often predictive of the later development of essential hypertension. Transient hypertension is a retrospective diagnosis, and if uncertainty exists regarding the diagnosis, these patients should be managed as if they had preeclampsia. Superimposed preeclampsia is the new development of pathological proteinuria after the 20th week of gestation in a patient with hypertension only during pregnancy, or it is an increase in blood pressure, increase in proteinuria, or decrease in platelet count below 100,000 per cubic millimeter in women with prior hypertension and proteinuria. Pathological proteinuria may be in the form of proteinuria exceeding 300 mg per 24 hours, or proteinuria more than 1 plus dipstick, or proteinuria more than 100 mg per deciliter in two random samples 6 hours apart. Heavy proteinuria when it is more than 2 grams per 24 hours or more than 2 pluses in dipstick. Risk factors for preeclampsia include primary gravidity or first pregnancy, multiple women with preeclampsia in any previous pregnancy or 10 years or more since last baby, age of 40 years or more, body mass index of 35 or more, family history of preeclampsia in mother or sister, multiple pregnancy, certain underlying medical conditions like pre-existing hypertension, renal disease, diabetes, and presence of antiphospholipid antibodies. Normally, trophoblasts invade spiral arterioles in the decidual plate, replacing their muscular layer, thus increasing their caliber. This will result in lowering the response to vasopressor. Placental bed biopsies have demonstrated that trophoblast invasion is patchy in preeclampsia, and the spiral arteries retain their muscular walls. The reason why trophoblast invades less effectively in these pregnancies is not known yet, but may reflect an abnormal adaptation of maternal immune system. This slide demonstrates the pathophysiology of preeclampsia. There is an abnormal trophoblastic invasion in case of preeclampsia if compared with normal pregnancy. Pathology of preeclampsia include generalized vasospasm, increased peripheral resistance, increased left ventricle contractility, thrombocytopenia, hemolysis, coagulopathy, endocrinal changes in aldosterone, antidiuretic hormone and renin pattern, renal pathology resulting in decreased renal plasma flow, endothelial damage, and acute renal failure. Other pathological changes include hepatic changes in the form of subcapsular hematoma, elevated liver enzymes, brain edema, thrombosis, and hemorrhage. Fundal examination may reveal vascular spasm, edema, hemorrhage, and retinal detachment. Decreased placental perfusion resulting in intrauterine growth restriction, uterine changes in the form of myometrial edema, necrosis of the muscle, and hemorrhage in between muscle fibers. This slide demonstrates criteria of severity in preeclampsia. Preeclampsia is considered severe if there is diastolic blood pressure 110 mm mercury or more, proteinuria 2 pluses or more, presence of severe headache, visual disturbance, upper abdominal epigastric pain, oliguria, presence of convulsions indicates eclampsia, elevated serum creatinine, thrombocytopenia, elevated liver enzymes, presence of intrauterine growth restriction, and pulmonary edema. Early in the disease, the patient may be asymptomatic, so mild preeclampsia is called disease of signs. Later on, the patient may develop headache, swollen lower limb, visual disturbances, anxiety, amnesia, fits, epigastric pain, and or decreased urine output. In examination, the patient will show hypertension, tachycardia, and or tachypnea, crepitation or wheezes over the chest, neurological deficits, hyperreflexia, petechia and manifestation of intracranial hemorrhage, manifestation of generalized edema, and small foldate uterus or undersized uterus. Please remember that preeclampsia syndrome is proteinuria hypertension with or without edema. Edema is not a must for the diagnosis of preeclampsia syndrome. Initially, blood pressure above 140/90, proteinuria 1 plus or more is sufficient for diagnosis. Later on, the patient will show sudden weight gain resulting from increased retained fluids, which manifests later as pretibial edema, swollen face, buffness of eyelids, and swollen hands. The only definitive treatment of preeclampsia syndrome is termination of pregnancy. Expectant management is adopted in selected cases only, like mild preeclampsia and uncomplicated severe preeclampsia remote from term. Management depends on severity, duration of pregnancy, and presence or absence of complications. Mild preeclampsia has no fetal or maternal complication except progression to severe preeclampsia. So, patients with mild preeclampsia can be managed in outpatient clinics. Frequent visits once weekly for blood pressure measurements and estimation of proteinuria. Also, fetal growth assessment and fetal well-being test must be done. No antihypertensive drug is to be given as it masks criteria of severity. Patients are informed to attend immediately if she developed any criterion of severity. The rationale in mild preeclampsia is prolonged pregnancy up to fetal maturity and then terminate. So, pregnancy will be terminated at completed 37 or beginning of 38 weeks in cases of mild preeclampsia. The rationale of management of cases of severe preeclampsia is to control and termination of pregnancy at the 34th week. No expectant management or conservatism after the 34th weeks because severe preeclampsia is associated with fetal lung maturity. Cases of severe preeclampsia must be admitted to high-risk pregnancy unit and controlled by hypotensives and magnesium sulfate. Patients beyond 34 weeks and less than 24 weeks of gestation, the pregnancy must be terminated. Patients between 24 to 34 weeks can be offered expectant management according to the control. If no response to the control, pregnancy is terminated at any time. Eclampsia is preeclampsia with convulsions and or coma. Please remember that the most common cause of fits during pregnancy is pre-existing epilepsy, but development of convulsions and or unexplained coma during pregnancy or postpartum period in patients with signs and symptoms of preeclampsia must be considered as a case of eclampsia until proved otherwise. The incidence of eclampsia is 1 every 500 pregnancies. It is more common in prime gravida. Commonly, it occurs between the 36 weeks up to term. Eclampsia may be antepartum eclampsia in 50% of cases, intrapartum eclampsia in 30% of cases, and postpartum eclampsia in 20% of cases. Convulsions during eclampsia may be due to cerebral anoxia, cerebral edema, and cerebral dysarrhythmia. There are 3 stages of convulsions. Initially, there is muscle twitching, rolling up of eyeball, lasting for 30 seconds. The second stage of convulsion is the tonic phase. It lasts for about half a minute, during which there is tonic spasm of the body, there is cessation of respiration, protrusion of the tongue, fixed eyeball, and cyanosis. The third stage is the clonic phase. It lasts for about 1 minute up to 4 minutes, during which there is alternative contraction and relaxation of muscles. There is congested cyanosed face. There is conjunctival congestion. There is bitten tongue and difficult noisy breathing with froth. Involuntary passage of urine and stool may occur. Finally, the patient will develop coma. Coma persists for variable period, and at times the patient is confused. Deep coma may occur if there is associated cerebral hemorrhage. Labor usually starts shortly after the fit. Eclampsia must be differentiated from other causes of convulsions and coma. Presence of convulsions in hypertensive proteinuric patient must be considered due to eclampsia until proved otherwise. Other causes of convulsions during pregnancy may be epilepsy, hysteria, meningitis, encephalitis, tetanus, strychnine poisoning, brain tumor, and uremic convulsions. Other causes of coma is hypoglycemic coma, hyperglycemic coma, uremic, hepatic, alcoholic, and cerebral coma. Investigation needed in the management of an eclamptic patient must include complete blood pressure, hemoglobin percentage, differential and total leukocytic count, total platelet count, coagulation profile, complete urine analysis, random and morning sample, urinary proteins, liver function tests, renal functional tests, serum uric acid, fasting blood sugar, ophthalmoscopy, imaging technique in the form of pelvic abdominal ultrasound, obstetric scan, CT brain and abdomen, MRI, fetal biophysical profile, cardiotocographic tracing, color Doppler study for fetal blood vessels, serum electrolyte and blood pH, ECG. Criteria of serious cases of eclampsia are called Eden's criteria. It includes convulsions 10 minutes or more, weak thread pulse over 120 beats per minute, systolic blood pressure over 200 mm mercury, respiratory rate over 40 cycles per minute, pulmonary edema, jaundice, and anuria. Management of an eclamptic patient includes the following items: general lines of management, control of convulsions, control of blood pressure, obstetric management, management of complications, postpartum care, and always remember that prevention is better than cure. General lines of treatment include maintenance of patent airway, oxygen administration, fluid management, organization of investigation, control of convulsions by intravenous magnesium sulfate, control of blood pressure by hypotensive drugs, obstetric management. The rationale of obstetric management is brief control for few hours and then termination of pregnancy. An eclamptic patient must be hospitalized. The patient is placed in an isolated room. Detailed history is taken from the patient or her relatives. Vital stabilization and control of blood pressure. Continuous drainage facility. Monitoring of vital signs and urine output. Antibiotics and H2 blockers. Fluid therapy depends upon a careful balance between overload and restriction. Fluid restriction has the possibility of exacerbation of end organ hypoperfusion and renal dysfunction. Volume overload may cause pulmonary edema. Our principle is accurate recording of fluid balance. Put in mind, losses during delivery and postpartum period and input-output deficit must be recorded. Please always remember that iatrogenic fluid overload is the main cause of maternal death in eclampsia. Diuretics are only indicated in presence of pulmonary edema and congestive heart failure. Pulse oximetry must be done. Selective monitoring of central venous pressure if blood loss is excessive. Intra-arterial pressure monitoring is indicated in the following conditions: unstable eclamptic woman, shooting blood pressure, obese women when non-invasive measurements are unreliable, hemorrhage exceeding 1 liter, and severe cardiac disease. After delivery, urine output is recorded hourly and every 4 hours. Each 4 hours block should exceed 80 milliliter. If 2 consecutive 4-hour blocks fails to achieve more than 80 milliliter, the guidelines for further management is demonstrated in this slide using 20 mg intravenous Lasix, colloid, and gelofuscine volume expander. For control effects, the following anticonvulsant drugs are used: magnesium sulfate, diazepam, phenytoin, and lytic cocktail. Continuous intravenous magnesium sulfate regimen is given as loading dose of 4 to 6 gram of magnesium sulfate in 100 milliliter of fluid by intravenous drip, slowly over 15 to 20 minutes. Maintenance dose is 1 to 2 gram every hour in 100 milliliter by intravenous drip. Monitoring of magnesium sulfate therapy is done by checking patellar reflex, respiratory rate, urine output, and serum magnesium level. Don't give the subsequent dose of magnesium sulfate except if the patellar reflex is positive, respiratory rate is exceeding 16 cycles per minute, urine output is exceeding 100 milliliter per 4 hours. If not, serum magnesium level must be estimated. Normal serum magnesium level is 1.3 to 2.1 milliequivalent per liter. Peripheral vasodilatation, flushing, and vomiting may occur at level of 3 to 5. Therapeutic level of magnesium sulfate is reached when serum magnesium level is 4 to 7 milliequivalent per liter. Depression of deep reflex occurs at 7 to 8 milliequivalent per liter. Arrest of deep reflex occurs at 8 to 10. Respiratory depression occurs at 10 to 12. Respiratory arrest occurs at level of 12 to 15. Arrhythmia, heart block, bradycardia, and cardiac arrest occur at levels exceeding 15 milliequivalent per liter. The antidote of magnesium sulfate is 10 milliliter of 10% calcium gluconate slowly intravenous. For management of status epilepticus, you must do the following: anesthetic consultation, nasopharyngeal suction, intubation, intermittent positive pressure ventilation, muscle relaxation, giving some medications like thiopentone sodium and diazepam 10 mg slowly intravenous, general anesthesia with positive pressure ventilation and muscle relaxant, and evaluation of intracranial abnormalities. Antihypertensives are indicated if blood pressure is exceeding 160 over 100 mm mercury, in spite of giving anticonvulsant and sedatives. Common antihypertensive drugs are intravenous labetalol, oral nifedipine, intravenous hydralazine, and diuretics in presence of pulmonary edema and congestive heart failure. Summary of management of eclampsia. If you have an eclamptic patient, you must do initial control by anticonvulsants, antihypertensives, plus or minus diuretics. If the patient is in labor, do artificial rupture of membrane and shorten the second stage of labor by instrumental delivery. If the patient is in labor and there is an obstetric indication for abdominal delivery, do lower segment cesarean section. If the patient is not in labor, further management will depend on control if fits. If fits are controlled, look at the baby. If the baby is dead, wait for spontaneous expulsion. After fetal death, there will be no deterioration of the maternal condition. If the baby is alive, do termination, either by lower segment cesarean section or induction of labor. Induction by prostaglandin E2 gel, artificial rupture of membrane, oxytocin, and misoprostol. If fits are not controlled, wait for 6 to 8 hours and then do termination. Before termination, you must assess induction score. If favorable, do induction by artificial rupture of membrane, oxytocin, and misoprostol. If unfavorable, do lower segment cesarean section. Indications of lower segment cesarean section in cases of eclampsia include uncontrolled fits in spite of therapy, unconscious patient, and poor prospects of vaginal delivery. Other obstetric indications as preterm baby less than 34 weeks, intrauterine growth restriction, non-reassuring fetal heart rate, oligohydramnios, malpresentations, and other indication for abdominal delivery as cephalopelvic disproportion. During delivery, an eclamptic patient must be carefully monitored for maternal and fetal conditions. Delivery must be well planned, done on the best day, performed in the best place, by the best route, and with best support team. H2 antagonists and antibiotics are given. Vaginal delivery is preferred if not indicated otherwise. Also during labor, the following measures are taken. No prophylactic methyl ergometrine is given. Second stage must be shortened by instrumental delivery. Rectal misoprostol must be given to prevent postpartum hemorrhage. Active management of the third stage of labor by 5 to 10 units of intravenous synthesonone or prostaglandin. You must be alert about postpartum hemorrhage with proper immediate management if it occurs. Give prophylaxis against thromboembolism. After delivery, magnesium sulfate must be continued for 24 hours after delivery and after the last fit. Regular monitoring of blood pressure must be done every 4 hours. Monitoring of the other vital signs for 48 hours. Antihypertensive drugs are given till blood pressure is less than 150 over 100 mm mercury. Patients are discharged on the fourth perboral day. Regular intake of iron and calcium during puerperium. This slide demonstrates the different maternal and fetal complications of eclampsia. These complications may be cardiovascular, renal, respiratory, hepatic, cerebral, eye complication, and obstetric complication. Cardiac failure, residual hypertension, DIC, oliguria, cortical necrosis of the kidney, adult respiratory distress syndrome, pulmonary edema, HELP syndrome, subcapsular hematoma of the liver, encephalopathy, cerebral infarction, cerebral hemorrhage, cerebral edema, cortical blindness, retinal detachment, retinal edema, antepartum hemorrhage or postpartum hemorrhage, fetal complication like intrauterine growth restriction, premature delivery, fetal distress, fetal demise. Thank you for your attention. All good wishes and goodbye.